Hello and welcome to a special edition of the Long COVID Advocacy Podcast. And I say special because today's guest is Professor David Putrino, a neuroscientist and rehabilitation specialist who has become a prominent clinical and research voice in long COVID research. He's a professor in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai, and he's the Nash Family Director of the Cohen Center for Recovery from Complex Chronic Illnesses, often known as CORE, which is a centre dedicated to the researching and treating infection-associated chronic conditions. Since the start of the pandemic, Professor Putrino and his team have worked with many patients experiencing long COVID and infection-associated chronic conditions. He has also been involved in education around CME-accredited long COVID, ME, and chronic Lyme disease education, and he's part of the long COVID open medical education program at Polybio. So without further ado, let me let in David. Welcome. Wonderful to have you here. We know that our audience are discerning and knowledgeable, and we've got the perfect guest today to give us further insights into long COVID. It's a real pleasure to have you here.
Oh, it's great to be here. Thank you.
I was saying in our little warm-up that our questions are fairly intense and detailed and get right to the point of those issues people really want to hear about. So I think this is as close to a warm-up question as I've got for you today. There are so few specialists in the field of post-acute viral illness, one of the newer terms for conditions like ME and long COVID. So what drew you to this field when so few had cleared a path before you?
Well, you know, from my perspective, I guess I have a hard time walking away from areas of clear need, and so from my perspective, it was really just that we had thousands of patients attending our clinic at Mount Sinai because after the pandemic. After the initial phases of the pandemic, I should say, it's very much still an ongoing pandemic. But after 2020, we just had, with Mount Sinai and New York being the epicenter of the epicenter, we just had so many people attending the clinic and saying, "What are you going to do?" And all around the country, we started to see this sort of progressive retraction of services toward folks with long COVID, toward folks who had all sorts of post-acute sequelae. And we just didn't want to be one more of those centers that was, we didn't want to sort of stick our head in the sand and say, well, the problem's over because the country is opening back up and the world is returning back to normal, or the new normal, or whatever, we want to call this phase that we're currently in. But the point was that there were very clearly people who were still extraordinarily sick. The data that we have and the data that was recently just published by Recover NIH shows us that the rate of new long COVID diagnoses has not slowed down since 2020. So it's not just a problem for people who are already sick. It is a problem for all of us moving into the future.
Yeah, it's not going away.
And so it was just very clear that it was clear to us and to our ethics and to, the sorts of people that I'm really fortunate to work with who don't turn away from a challenge, that this was something that just had to continue so that people could have options. And crucially, in the work that we do, something that had to continue in a way that's covered by insurance, as opposed to, hey, let's create, a self-pay clinic that's very, very expensive and, boutique-like, and, because surely we could do that, but that's not solving a problem. That's, that's just, it's solving a problem for a very small percentage of people.
Yeah. And it could potentially, give a certain impression about, like a fashionable illness, as it were, which we've had problems like that in the past.
Yeah, absolutely. We all know the tropes.
Brilliant. So, is it fair to say that that medical education and attitudes have consistently failed patients with ME and long COVID. And to the extent that that's the case, what do you think are the roots of that failure? What's gone wrong in how medicine conceptualizes complex chronic illness?
Yeah, I do think it is fair to say that medical education has so far failed people with long COVID and ME and other infection-associated chronic conditions and illnesses, things like chronic tick and vector-borne illness. And you know, I think that the sort of the structural roots of the failure really focus on the fact that healthcare doesn't do well with complexity. We don't like things that we don't understand. We tend to, you know, if we take the words of Susan Sontag, we tend to metaphorize illnesses we don't understand. So we tend to create stories around illnesses we don't understand. You know, Sontag wrote about being told that she got, you know, being told by a doctor that she got cancer because of her cancer personality. You know, that was in the 80s when talking about a cancer personality was a thing that people did, you know, and we've thankfully moved beyond that in oncology. But I think that in invisible illnesses and illnesses that are poorly characterized and poorly understood by mainstream clinical practice, we're still in this phase of metaphorizing. It's easy. It's, dare I say, lazy, but lazy is easy to sort of say, well, I don't, you know, I can't really see why this person is sick. All the tests are coming back normal. It's probably in their head, you know? And I think if we look at some of the education around ME/CFS over the decades, you know, and we look at some leading medical schools, you know, someone showed me an image that is, you know, a slide in a presentation about ME/CFS that was taken from, you know, Harvard University Medical School, where, you know, the depiction of a person with MS, there is a cartoon and they're sitting in a waiting room and they're kind of sweating, you know, and they've got a book under their arm, like a medical book, and they're frazzled, and you know, and so the depiction there is, here is this hypervigilant, prone to anxiety, high health conscious individual who's sitting
with the temerity to try and learn something about their illness.
Exactly. And that, you know, that really, you know, when that's the way that you're teaching students, you know, that creates stigma from the outset. That creates a mindset from the outset that when faced in the real world with a person who says, this is my diagnosis, it's long COVID or ME/CFS, immediately they're going to think back to that lesson and they're going to say, oh, well, you know, I learned about this and this is probably psychosomatic, or this person's going to come at me with lots of medical jargon that I don't really understand. And, you know, and so I do think to that end, you know, we have failed to date. I think, you know, one thing I'll say that is hopeful is that as my team and myself go out and do medical education ourselves, what I'll say is, like, I don't think that anyone really wants to stigmatize patients. I don't think that people want to not understand what their patients are going through. If for the majority of cases, you know, I don't think it's fair, just like it's not fair to characterize people with ME/CFS or long COVID in the way that I just described in, you know, some of these textbooks. It's not fair to characterize the majority of clinical providers as heartless, unfeeling individuals who don't want to help. I think that the truth in the middle is we have a lot of folks who just don't get a lot of targeted education, get frazzled, make bad decisions because of a lack of education. And what has been a learning of mine as I've been going around the the country, in the United States, and in some cases around the world, teaching, is that people meet me with curiosity and actually feel really relieved to be given a roadmap of, well, if someone walks in and says they have long COVID, here's the first thing you should do, and then here's 10 more things you can do, and then here's a bunch of medications you can try, and so giving people a roadmap immediately releases a lot of this anxiety, because I think a lot of this anxiety from providers comes from like, well, I don't know what to do when this person walks in the room. I don't even know how to identify what they have. And we've even had surveys where we ask providers before the education, are you convinced that a diagnosis like long COVID is real? And in one survey of 200 providers, 30% said no. And then after an hour and a half of education, 0% said no.
Wow.
All of them said, oh, I actually, I actually believe that like long COVID is legitimate. And so that was just an hour and a half showing very well-cited literature, educating people. So I think people are open to it. They just haven't done that before.
What a precious hour and a half.
Yeah.
With, when you think about its potential impact on goodness knows how many thousands of patients, or, that's the power of education models, isn't it?
Exactly.
And what really struck me about what you're saying is about that response to complexity. When we think of what, broadly speaking, Western modern medicine does best, it loves acute trauma and localized single point conditions, doesn't it? From a broken leg to a located cancer, and it's on, and you can save that person, and you know what to do. But when you're talking about multifaceted, complex presenting, then it suddenly becomes the flowchart model doesn't work. And it's interesting, we'll explore a bit more what you mean by like the roadmap instead, which is a bit more complex than do A or B, isn't it?
Exactly. And you're so right, even when we talk about the systemic issues, even just when you think about the way that we're invited to speak at conferences, and I'll be told, hey, can you keynote at this conference? You seem to know a lot about long COVID. Can you keynote at this conference? 25 minutes to talk about how to treat long COVID, and I think that that's because in less complex illnesses, we have created such an algorithm that you can, in a simple, well-characterized pathobiological state, you can say, this is what's going on. This is the pathobiology that's well characterized. These are the drugs that hit the targets. This is best in class. And here are some new cool drugs that are in the pipeline that should be done in 5 years. Good, presentation over. Whereas we're not there with complex chronic illness. And so even the challenge of being told, present something in 25 minutes, if you're not careful, you can do more harm than good to providers, because suddenly they're like, well, this doesn't seem like a well thought out model for a disease or an illness, so the system sets you up to fail sometimes if you're not careful. And I often preface a lot of my talks when they're very short with like, listen, we're not going to get through everything, so I'm going to give you some real basics to think about what we're doing.
Yeah, and you can just, in that time, you can just about open up people to what they don't yet know they know, what they don't know that they don't know. Absolutely. Thanks for that. And so, I mean, we've touched on this, but are there any sort of particular textbooks or training models or guidelines that you think have like disproportionately shaped clinician attitudes towards ME and long COVID?
I think, honestly, from my perspective, what I hear the most from providers is there are so many books now that are written from the patient's perspective that, providers are always telling me like, this was the thing that turned it around for me, like reading about this person's story or reading, a couple of them that pop into my mind are, Megan O'Rourke wrote The Invisible Kingdom about chronic Lyme disease. It's such an incredible way to think about chronic illness, complex chronic illness. She writes it from such an empathetic standpoint that you can almost feel everything that she's going through. And providers have told me that that really gives insight into, like, this is what it feels like. Books like Brain on Fire, but these books that give very visceral descriptions, because I think that that's what's needed for providers. I think what's needed is that you can't trust the textbooks. So let's show you, with our most eloquent people who are representative of the illness, let's show you what it really feels like to be sick with these things.
Does that feel like it's a emerging pathway in medical education, that these are with respect to certain complex conditions, you need to start by listening to these people? Is that something that people are acknowledging as valid? And
100%. I can't speak for every medical school in the world, but I can speak for the medical school that I work at, and increasingly patient experience is being built into the medical education curriculum. Increasingly, and including in the classes and the courses that I teach, like the last class of the semester will be meeting with patients who have the condition and conversing and talking and asking the questions that you want to ask. And I think that for extremely stigmatized or for poorly understood illnesses, it's even more important to do that, because I think that nothing removes doubt from your mind that someone is desperately ill than seeing that person desperately ill and having the lived experience of seeing someone in some of their toughest and most vulnerable moments. It's undeniable when you see someone with severe ME, or when you see someone with severe long COVID, severe Lyme disease.
I hope so. I'm going to jump script a little bit there, just to reflect on that, because perhaps there's a different, that undeniability, as it were, because it may well be that in the case of the medical education context, where you are there to learn, they are there to learn about conditions, but in the actual clinical setting where you're dealing people with acute conditions, and presenting in very severe ways, we know from, and people watching this many of them will know from personal experience how unsympathetically they can be received, and how violently they can be disbelieved. So is there a disjunct, between those settings then? And does that make it even more important that the medical settings prepare them for those clinical ones?
Yeah, I definitely think, I think in the educational space, and learning patient stories, seeing, all of these things that I was talking about, and getting a feeling of the lived experience. How that's different from the clinical experience is, in a clinical setting, a clinician is stressed. They're probably already 50 minutes late. They're trying to get through a session. They're trying to get through a session that should take 2 hours in 20 minutes. You've got a patient who's stressed because they're, first of all, extremely concerned that they're not going to be believed. Second, they've probably got a laundry list of things that, they're like, okay, this is the last time I'm going to see this person for 3 months. I've got a list of priorities that I want to achieve in this meeting. And, acrimony ensues, unless you're a very special kind of provider, or a provider who's been appropriately trained to sort of de-escalate, everyone take a breath, and go through, bit by bit, what can we do for you that is most meaningful, so that you have some hope and some stuff to do, and and some new things to try over the next 3 months. Because I think what I've heard most from patients is that what everyone dreads is waiting 3 months for an appointment, feeling like garbage, going into that appointment, kind of just being disbelieved and gaslit, and walking out with no new insight, possibly having paid a lot of money for the appointment, possibly not, but either way, it's just not a great feeling.
Yeah, it's precious either way. Yeah.
And anything that you can do to prevent that. I hope that explains, but to my point, like creating a safe, I hate to say it, but creating a safe space for people to actually experience, have a lived experience where it's like, it's not that the person with the condition is asking anything of you, other than to listen and other than to believe. You're not being expected to help, or you're just being asked, I just want you to see what the truth is.
My specialism is in school education, and very similar things apply compared to when you're there controlling the classroom, compared to when you're talking about the situation with others and being given the chance to reflect. And that, I think, what's very similar also is that idea of control panic. Clinician or practitioner panic. They need to feel that they're in control of the situation, that they're expected to be in control of the situation and know what to do. And anything that threatens that through complexity or through difficulty in communication, it all threatens that, and then it can lead to knee-jerk responses.
Yeah.
Can you tell me a little bit more about medically unexplained symptoms, this idea, and their role in shaping doctors' attitudes towards long COVID and ME patients? Do you think these sort of frameworks of unintentionally entrenched, perhaps psychosomatic assumptions in the way that are now difficult to unwind?
Yeah. I think, what I can actually do is I can share a personal story on this front, which is that, I think that, unfortunately, what can happen is, based on the way that certain terminology emerges or is coined, it can sort of dictate the stigma that it holds, even if the terminology itself doesn't necessarily seem objectively offensive. So when I see the term medically unexplained symptoms, that's fair enough.
It should be a neutral term, right? It just means we haven't got the answer yet. Yeah.
And right now, they're as yet medically unexplained. Like I can understand that term, right? And interestingly, a cousin of medically unexplained symptoms is medically unexplained physical symptoms, MUPS. Which is also a term that was thrown around a lot. And when I was first entering this space, when my only experience was with long COVID, and I'd only been sort of studying it for a couple months, I heard the phrase medically unexplained physical symptoms, and I was like, oh, that is actually, a good word for, a good phrase for it. And I used it as part of a framework of, like, people have these medically unexplained physical symptoms, but if we dig into the drivers, we can find out that they are actually explainable, which is, now that I know the context, is quite funny. And it was actually a patient who reached out to me afterwards and very kindly said, hey, I really loved your presentation, but did you know that, like, that's a really problematic term that you used? And I was like, oh my God, no, I'm a newbie in the space. Thank you for letting me know. Let me educate myself. And of course, I see that medically unexplained symptoms sort of just emerge from, hysteria and somatization and psychosomatic. And so all of this is to say that, unfortunately, I think we need to leave, even if the phrase is innocuous at face value, it needs to be left behind because, because what we see in all language. So if we move away from medical language, this can be, racially charged language. This can be just generally swear words. We always learn that groups that are stigmatized and groups that are minoritized historically we tend to have to keep changing terminology to protect them because stigmatization has been happening and certain words are used as dog whistles or as ways of continuing to stigmatize these folks.
Yeah.
And what we need to do collectively is figure out, okay, well, when people say that is code for that. So let's move away from saying that. Let's come up with new phrases. And I think that's where we are with MUPS and MUS, is it has to go because, it comes from a time and a place when people were being told that they needed the rest cure or the ECT, and that's just not acceptable. And, it's not where we want to be scientifically.
Yeah, and I guess you can relate it back to that kind of flowchart model, if you like, in the sense that if you start from a place where you believe that effectively the medical system has structures that work for patients in a sort of flowchart way, then anyone who doesn't fit that, by default, the problem is with them. So rather than the fault is on us for not yet understanding it, the fault is theirs for not fitting into the system, thereby implying that there's probably nothing wrong with them in the sense that we would normally imagine. Yeah. Thank you. So, I mean, in the UK, the ME delivery plan here promised sort of improvements in medical education. But what materialized were sort of 3 voluntary e-learning modules, and freedom of information data from Lucy B showed very low uptake of these. So why do we repeatedly see these sort of minimal optional interventions rather than structural curriculum reform?
Yeah, I think largely we run into these problems because we run into these problems because change is hard. Systemic change is difficult. And so one of the things that I always think about is even if we move away from long COVID, infection-associated chronic conditions and illnesses, and we just think about working in a hospital, trying to change the way providers do one thing. Frequently, it just, it takes years, and you get resistance from every angle. All of this structural bureaucracy, depending on you doing things one way, and no one ever thinking for once about the patient. Everyone just thinking about like, no, this is the way we've always done things. So why would we change that? And so, I think why the reason we repeatedly see these problems is because there's not enough people making noise at multiple levels, because this is a thing where you need to make it everybody's problem to drive the structural change. And I do think that, and maybe I'm just biased because of what my institution is doing, but I do think that we are starting to see structural change. I do think we're starting to see institutional change because we are engaging in infection-associated chronic conditions and illnesses and curriculum at our medical school. First-year medical students are getting taught it. They're sitting in lectures that I'm giving, God help them. And we also have